So atrial fibrillation is one of those rhythms that we see in the hospital and in the outpatient setting a lot, and it's one of those things that is very, very uncomfortable. And as a cardiologist, not just atrial fibrillation, but there's a lot of things that I see as a general non-invasive cardiologist. First of all, what is a general non-invasive cardiologist? So I've done my 4 years of medical school, I've done my 3 years of internal medicine residency, and then I did an additional 3 years of cardiology fellowship. So after I did that, after I did my 3 years of cardiology fellowship, I had the opportunities to potentially do a little bit more, whether it's interventional, heart failure, congenital, but I love general cardiology so much that I did not, and the market was popping that it financially didn't make any sense. So it wasn't a difficult scenario for me to choose general cardiology as my specialty. So the question is, what do I do as a general cardiologist? Well, like it states, I am a general cardiologist, so I see a little bit of everything. I see chest pain, I see heart failure, I see atrial fibrillation, palpitations, I see just a weird shortness of breath, dizziness. I see issues with valves to make sure that that's not causing any problems. And we can investigate that with a procedure called a TEE, a transesophageal echocardiogram. Now this procedure looks at how well the heart is functioning. It looks at the heart, and not just that, looks at the heart valves, looks at if there's any fluid around the heart, looks at how well the heart is squeezing, and just gives us a lot of information to help make that diagnosis, or help assist with the diagnosis and prognosis, and see how someone is progressing. Like I said, atrial fibrillation is one of the biggest things that we see people for, so this TE lets us make sure that there's no clot in the valve, clot in the left atrial appendage. If there's not, we can get people out of atrial fibrillation with a cardioversion. It's not a one-solved situation because some people can go back into it, so risk factors, obesity, sleep apnea need to be treated. But like I was saying, other things that we see in cardiology includes chest pain. Wanting to make sure that your chest pain is not due to a heart attack, not due to potential blockage of your heart arteries. I get really concerned when someone is having chest pain here, and that pain radiates to the shoulder. That pain is worse with exertion. Pain gets better with rest. Definitely want to be seen, probably by a medical provider, probably by an ER, to make sure that your discomfort is not due to a heart attack. If it potentially is, then you're going to need a cardiac catheterization. This is a procedure where we look for potential blockages. I do find that there's a lot of individuals that when they come to the hospital, their pain has subsided, so they don't really need to have this test done. So what else can you do if you're not having any more chest pain, but there's a concern that you may be potentially having heart disease? You can do an echocardiogram to look at how well the heart's squeezing. You can do a stress test. If those are abnormal, once again, we will proceed with doing a cardiac catheterization to look for blockages. So when someone has had a cardiac catheterization, what typically happens afterwards? So you can imagine that if there's no blockage, then you would do nothing. You would continue treating lifestyle changes, up titrating medications if necessary. If there's a blockage, then we have to consider how bad it is, and then we may potentially put a stent in. If there are several blockages, then we have to consider coronary artery bypass graft or high-risk PCI, putting in stents in high-risk patients. And if there's no blockages, then we have to go back and look at other potential non-cardiac causes that can be causing your chest pain. Like I was saying, there's a lot of different things that we see in cardiology, and one of it is heart failure. So heart failure is when your heart's not squeezing appropriately. The heart is not meeting the body's demands. So when that happens, it can be potentially due to the heart not squeezing appropriately or not relaxing appropriately. And what typically happens is that the fluid will back up. It can back up into the legs, causing pitting edema. It can back up into the stomach, causing swelling, can back up into the lungs, causing shortness of breath. Especially when they're laying down, it can cause a shortness of breath called paroxysmal nocturnal dyspnea. When they lay in a recumbent position, they become more short of breath and they gasp for air, sit up to be able to breathe better. So we do an echocardiogram to look for what type of heart failure you have, and then depending on that, we'll come with the treatments, whether it's a cardiac catheterization to look for blockage as the reason as why it's not squeezing well, or treating risk factors such as sleep apnea, obesity, etc. So this is one of the reasons that I love cardiology, because I get to see a little bit of everything. I see heart failure, palpitations, chest pain, atrial fibrillation, crazy abdominal rhythms, other than AFib, such as ventricular tachycardia, ventricular fibrillation. And it makes it very, very not mundane, because we're seeing a lot of different things, and we're able to just care for people appropriately and let them know what's going on. A lot of times these individuals have been going on for weeks, have been having issues for weeks, months, sometimes even years without any explanation. And I take pride in being able to help solve that puzzle piece. If you guys are thinking about the medical field, I think that medicine is amazing. Cardiology is the best field. But if you got any questions, leave them in the comments, and I'll do my best to answer it in the comments, or even better, sometimes even make a video out of it. If you like this video, you're definitely gonna like this one.